Yes, we are talking trigger points today. One of our members, Brian Dingzor, who I think just signed on here. Welcome in this morning, Brian. And welcome in, Mark. I hope everybody's well today. Another gorgeous day in Portland for what might rival the best fall that I can remember on record in our particular area. This is phenomenal. I'm looking out the window here, you guys over my shoulder on Facebook. Get a bit of a glimpse. Still got some fall color out there. Gorgeous blue skies, nice crisp temperatures. Yeah, I was just reminiscing or thinking about this anyway the other day, that this view from my desk and how it changes through the season, and that's going to be all interesting shades of gray and brown here very shortly. But a delight for the fall colors right now. Let's see. Welcome in those of you that are dropping in on Facebook Live. Just kind of chit-chatting a bit while folks come in. Folks have asked what it is that I'm drinking, since clearly that's not just coffee. It's the season, man, and my wife kind of gets into these flavored coffees and stuff, so I made myself an eggnog latte this morning, and it's delicious, and I don't feel guilty at all because it's sugar-free, but I'm probably damaging my DNA in some way that will only become apparent in a few years. Let's see, this past week, let's see, we'll talk briefly about some past cases. I'll chat about those, and then we'll move on to the topic of today, with about myofascial trigger points and what our current feelings are about those, and what the current evidence suggests, and so forth. In the past several weeks, I've mentioned at least one case of a retired Marine with a lumbar instability and intermittent incontinence. Some of you that have been paying attention have noted that these meetings that we're doing, I'm now uploading to the NeuroCentric approach site. That's the main website, neurocentricapproach.com, rather than the online recording site, which is academy.neurocentricapproach.com. But I upload the transcript, the YouTube video link on the NeuroCentric approach site, and I did put one up labeled intermittent incontinence on this particular case. This past week, the first week working with this individual who could reliably worsen his pain with any lumbar extension, and if he had lumbar extension with additional left hip flexion, like reaching with his left leg forward and then externally rotating it as if he's making an awkward step forward and to the left, that also, in addition to pain, would put him on the edge of an incontinence event. So you might ask, why in the hell am I playing with something like this? That sounds like something that should be in a surgeon's office. And indeed, I feel similarly, but this individual wants to trial a conservative bit and see if he can get out of, stay out of the surgical algorithm for long enough time for technology to improve, et cetera, et cetera, et cetera. So the first week, We went on very baseline DNS protocols of establishing intra-abdominal pressure in a sitting position and raising the legs in the sitting position and developing some sense of control over the pain that he feels, increased pain that he feels with hip flexion in the left leg. The second visit, we moved him into supine and started working the same process using developmental postures from DNS. Log rolling posture was my go-to there. The third visit, we began with that, progressed him a bit to some lateral movement with low oblique sit position, and then stood him up, since the majority of his day is not spent laying on his back in a construction environment. He does most of the bidding for his company, so he walks around quite a bit and evaluates properties. And for that, to help work on that same intra-abdominal pressure and adding to his ability to brace when needed, we used, I borrowed a page out of some of Dre Spina's work with his FRC material, as I understand it. And I did something called, that I refer to with my patients as planting the flag. I used a staff and had the patient take that staff and stick it, imagine they're planting a flag and sticking it very vigorously in the ground. And I did that with both the same side in this particular patient, since his symptoms were mostly provoked with left hip flexion. I had him first work an ipsilateral pattern per DNS by planting the flag with his left hand and then stepping with the left leg. And then with a contralateral pattern, which they would consider to be a slightly higher level of development, and tried to do the same thing with that. That was a bit of a game changer for him. He found that the reliable pain with extension and with left hip flexion got much better with both of those. And we were able to build on that then to the beginnings of a little bit of lateral movement. Those of you familiar with DNS know that we like to work with sagittal plane developmental patterns first, and then often frontal plane, and then we move to transverse plane patterns. So I started working on some frontal plane work with him using what I refer to as skaters. The skaters, just for him, certainly would be far too dynamic, but we just started dancing together. I'd stand in front of him and step from side to side, and he would do the same thing. And now he's starting to work on pulsing his stabilization strategy. And where are we getting that information? That's off of Stu McGill's paper a number of years ago, where he went to George St. Pierre's gym outside of Toronto and was investigating Bruce Lee's double pulse notions of how to stiffen to generate movement, then relax to allow speed to build up, and then stiffen again on impact on a punch or a kick. And that McGill found in that paper that all of the members of GSP's gym were very able to very quickly marshal up intra-abdominal pressure by way of EMG that Stu was using to study that. But the best athletes in the gym, the ones with the best record in their fighting career, were able to turn it off, turn that stiffness off faster. So that we're interpreting to mean something important for athleticism in general. So when I work with patients on this, as we start to talk about stabilization, My observation over the years is that patients will unconsciously then start to hear that they need to be tighter, and they will stiffen more and more and more, and their core, all of the muscles involved in that desirable intra-abdominal pressure, they start holding them tighter and tighter and tighter and tighter. And most of you know that that has a point of diminishing returns, certainly over time, and maybe even in short term, that we're looking for the lowest level of necessary intra-abdominal pressure for the desired task. If I'm working with my power lifters at Kabuki, then we want 100% maximum pressure during a grinding movement like a squat or a deadlift. But if I'm reaching for my coffee cup here, I'm not prepping for it by going, okay, I'm anticipating this. Because it's kind of hard to drink coffee effectively when you behave in that way. So what I try to talk with my patients when I'm doing this is that we do want to turn that on, but we also want to turn it off. And I'll have them practice that using a strategy that Mike Rentala taught me a number of years ago. You can practice it during the day while you're driving. You drive hopefully safely with one hand on the steering wheel, and you take the other hand and put your fingers on 2 of the 4 quadrants that we pay attention to when we're teaching breathing and bracing per DNS in those particular patients. And the 2 fingers on the front flank and the thumb on the rear flank. And we have them to practice breathing into that. Helps with road rage, kids, and also to pop that that pressurization and practice turning it on and off again very quickly. So does anybody have any questions regarding any of that or any comments?
Will he keep seeing you, Philip, for a period of time just to see how it goes? Or
hey, Brian, give me a view that doesn't look like your bike's on the ceiling there.
Oh, what's that? Can you hear me?
You're loaded for bear up there, man. Or you?
Yeah, we got a lot of kids, so it's a lot of bikes.
Lord, good Lord, man. You're one of those guys on the bike path that comes through, and it looks like, you know, something out of the Peloton on. No, it's just my family.
Yeah, that's true. It's just the Peloton family. There you go.
Awesome. So you this particular patient, yes, it's a he, and he will continue to see me for right now. We've probably got another 2 or 3 visits, I think, worthwhile in our trial that we're doing to see if he's able to get some reasonable benefit. I'm very encouraged so far with what he's feeling. His desires in terms of function, you know, he's a former Marine. He's lost about 50 pounds in the last year. He's a relatively high functioning guy in many ways. Oh, look, Mark's now showing up with the competition. We're gonna get into that. All right. Okay, I see how it's rolling there, Heller. All right.
What's he doing?
He's showing us his bikes and his.
Well, I'm outside where it's 55, and that's hot for us. So.
Yeah, it is. You know, those of us in northerly latitudes are getting the long stick in the draw this year with these delightful temperatures and stuff. So yeah. In response to your question, Brian, yeah, I'm going to see him again. You know, we'll try to meet his levels of function and what he's looking for, and then we'll weigh referral on based on his desires for future function, balance on, and cost benefit analysis with the
Well,
potential risks associated
with
with.
with patients like these where you do suspect a lot of instability, are they pretty much told that, hey, this is pretty much a lifetime, exercises daily, no matter what, in these cases, would you say?
Yeah, I think part of what I try to do with these as well, Brian, is to cultivate a sense of sport and athleticism in my patients in general. I find that helps, and there is some evidence to support that as well. That when you move a person from a self-perception of being a patient or being a victim by the pain that they're feeling, that they are an athlete in training, and you give them objective things in that, we'll continue the analogy and call it a training plan, that they can track, then I find that their compliance with home exercise is quite a bit higher. And in this particular situation, I mean, I'm blessed that I'm able to get patients by and large that are quite motivated to be physically active and to develop some sense of agency over the situation that they've got. That's kind of the reputation in my local community that I've built. And so I don't have to fight with patients often in that regard. And candidly, if I do have to fight with them in that regard, I have as you and I have mentioned before, a bit of a straightforward come to Jesus meeting with them. It's like maybe we're not the best fit for each other, and I refer them on to other colleagues that are more into the kind of treatment plan that those patients are more used to, maybe more passive care.
Okay, that's a very good case. I got a gal who came in with, she was told bilateral plantar fasciitis for over a year. She was actually put in a boot with her right leg. But when she pointed where she has the pain, it's more right at that tibial nerve, right where it branches into the plantar nerve in the arch of her foot. And just to give DNS a few props here, but she came in, had pain walking. I just had her do a dead bug with some intra-abdominal pressure. She got up, walked, and her pain reduced by 50%. And I said, get rid of the boot. And so my question is, in school, I went to school over 20 years ago. Instability really just wasn't taught at all. You know what I'm saying? We're taught bones are out of place or joint restriction. I don't know what you guys were taught, but instability was only taught if there was like major trauma, and you look for it on X-ray. But it seems like Stu McGill and you, and just what I've kind of learned in the last few years, is I think it's a lot more common than what we realize, especially with like the movements you said. He'd lift his leg up, he'd get pains because of that hip flexor pulling on the spine. But also, do you notice with some patients, they bend forward and they get that jolt of pain when they go down or when they're coming back up? I personally think that's kind of related to a instability as well, don't you? To a degree, or
entirely possible. Again, the way similar to what you just described, and kind of playing a DNS card. I would cue them often kinesthetically by smacking them, kind of briskly in their flank, and say, here, make that tight, and then do the movement again. And at arm's length, that's a very quick and easy screen to my mind, that if we've got a bit of a stabilization problem there, and we can teach the patient a little bit of how to recruit that in a way that's not a high threshold stabilization strategy, then often they will feel quite a bit better. And what I'm trying to do with that, and the way that I just phrased it, is to try to dance through that minefield that has developed over the years between the call and response between Peter O'Sullivan and Stu McGill on this. I don't know that they've ever actually, gone head to head on any of this, but Stu has has talked quite a bit about these micro movements and such. And then as a result, sort of as I was just talking about, people tend to they interpret that as being really, really tight. They have to be tighter. They have to be stronger in their core. And then when they do that, sometimes they wind up with tissue acidosis from the type 2 skeletal muscles that are being held in those positions, and that can be a source of nociception. They then develop potentially sliding dysfunction or a frank entrapment of the neurology in the flank and in the lumbar area, and that starts to look like Main syndrome. Peter O'Sullivan pushes back on that, and I think justifiably so, but I don't think it's because of anything Stu said. It's more, probably more what Stu didn't say in that. And that's where I'm trying to fill in some of those gray areas with what I've learned over the years and what my understanding and conversations directly with Stu has been. So, I think we can develop a better way of incorporating that DNS information in that instability argument. Now, beyond Stu, if you just step back and do a PubMed search on lumbar instability and talk about some of the things that are at play in that lumbar instability. In my clinical companion to Fix Your Own Back course, I mentioned a paper that Michael Shacklock brought to my attention. The principal investigator's last name is Dombrowski. For those of you that are on here that have seen or that have taken my course, you can just pull your PDF of your course notes up and search for that name. Dombro, like Dombro, WSKI, I think is, I think I got that right. But part of what they showed was with a very high-tech two-way X-ray that then was turned into CT, an active CT. They had patients, I think it was 7 patients in that study, patients with back pain and suspected instability. I think they might have even been shown in a flexion extension film. I think they may have done that and then correlated the findings on the flexion extension study with what they found on the CT. And
Philip.
Hang on a second, Mark. And then what they learned in that Dombrowski paper is that in the excursion, in that flexion extension excursion, whereas many of us with motion X-ray, are taught about that 3 millimeter translation and whether or not that represents frank instability. In the Dombrowski paper, they showed that it's not just the sagittal plane movement. It is a 3-dimensional movement of that instability and can be shown to slide sideways, and it can even go forward and then come back at the end range. So it's fascinating to think of that. I'm 1 second, Mark. Jerome Friars over here on Facebook, he's mentioning that Stu talks about relaxing the muscles in standing and that they need to be shut off in certain postures, and certainly there. Just an FYI for those of you on Facebook over here too, for my old brain, it's a little bit difficult to manage both of these semi-adeptly, and I'm going to prioritize folks that are members for the NeuroCentric Approach Online Academy, and they're over here on Zoom, and some of you guys over here are as well. But it's, if you really want to get questions answered and want to interact with me better, the Zoom feed is the better place to go. Mark, what you got?
I just wanted to ask you about that thing you started discussing in the first couple of minutes, some kind of side-to-side movement thing you were doing with somebody. What was that? And then, but before you answer that, I just want to appreciate that I've always taught bracing. I just said, okay, don't suck in, push out gently, and I just put my hands in the front side. And you added that 4-point thing, and that's huge. Just it's, you know, to assess all that and then have the person aware of where they're not firing seems real helpful. But, and the question is, what was that side-to-side thing you talked about at the beginning of this session today that you were?
So first off, the 4-quadrant stuff, that's something that in the Principles of Loaded Movement courses that the coaches at Kabuki Strength teach. That's part of what we've gathered from DNS and we find particularly effective in that population. Part of what we've done with those athletes is literally change the bracing strategy under bar for the major lifts, particularly in squats and deadlifts for power lifters. Previously, if you go through most of the coaching strategies that have been demonstrated over the years for moving heavy weight, the first coaching strategy often is to perform an anterior pelvic tilt and really make the lumbar extensors maximally tight. And that indeed in a sagittal plane will help to manage potential buckling forces under load. But in many people, read the Scottish hip kind of thing, the acetabulum will bump into the femur at depth, and often that depth in the individual will be too high to be a competition squat or a competition squat in this case. And as a result, what we've done is try to bring them off of that exuberant anterior pelvic tilt and exuberant tension in the lumbar erectors, and we coached them into a 4-quadrant even bracing strategy. And indeed, over the 15 years that I've worked with these athletes, across the board, 100% of the time, when one of them is injured, this is a, what is it, a post hoc ergo factor hoc or whatever analysis, when one of them is injured, one of those 4 quadrants, they're not able under a challenge with my hands in the clinic to make that area stiff and robust, and they're often not able to breathe into that area. So not sure if that's a cart, not sure if it's a horse, but thought it was worth mentioning. You asked the lateral stepping thing and what I'm doing there. That's a riff on what are in some circles referred to as Haydens, H-E-I-D-E-N. Some of you are old enough to remember a U.S. speed skater by the name of Eric Hayden, who was the namesake for that. And those exercises, also known as skaters, have been taught since he kind of brought them to some awareness a number of years ago. So the way I start with that, Mark, and again, I'm using it from a DNS perspective to start to move into frontal plane. And more specifically, for a lot of these patients, I find it to be a dynamic glute exercise that's quite helpful. During the pandemic, I used it quite a bit, along with Bulgarian split squats as a leg workout, or something that you could do at home to use body weight and get a bit of a HIIT program going. So the way that I coach it is I'll stand in front of the person, and I'll start by just in an upright position, stepping back and forth. I'll say, do what I do. And I'll just have them mirror me, and we'll both step back and forth at the same rate. And then I'll have them to stop and drop down like they're playing shortstop. There's a Stu McGill cue. And then the hands come up like they're ready. And then we're going to dance back and forth in the same way. And then I'll start to increase the excursion as I step back and forth and get a little bit of a hop in it. And everyone will start going up and down then. And at that point, I'll try to coach them into keeping their eyes level to the horizon, no bounce up and down. So imagine they're skating, and then we'll get our arms involved as well. So then we get a contralateral gait pattern going on this movement. And you can take that about as far as you want and get a very lovely training effect in the gluteal muscles on that. You can get winded quite nicely, and I even use it with my post-ACL reconstruction or prehab athlete performance drills for folks for ACL repair or injury prevention strategies. And what I'm doing there on the coaching is on the landing, we want to stick the landing like a gymnast and not have a whole lot of upper body sway, and really work on controlling that. And I'll have those patients also do it in front of mirrors if they can in a gym and kind of watch their movement. A lot of ACL patients I've seen that kind of dynamic movement in front of a mirror makes some lights come on oftentimes, where you'll see that if they do a that kind of movement, and or you do something that looks like a low box jump in the dynamic portion of the ACL rehab, you'll see as they land a tendency to move into a valgus position that has a putative injury risk associated with it, that I'd like to try to put a bit of a break on. So hopefully that clarifies a bit, Mark. Welcome in, Guillermo. Nice to see you again this week. One thing I do want to drop in here, a little commercial break, shall we say, at the 30-minute mark. Many of you that are involved in this, certainly over here on Zoom, and many of you over here on Facebook Live. And welcome in, Dean. It's nice to see you joining us this week as well. Most of you that are on here are lifetime members on the site. You were, to my mind, granted, I'm quite biased, but to my mind, it was a pretty damn good deal. You got roughly, so far, 35 hours of continuing education in an online format for the low, low price of $3.99 when we launched this thing. As I said at that time, the cost is never going to be lower than that again, and I'm true to my word. It won't be. It will steadily go up. But I will continue to make it better or available at different points in time. And here's the first one. It is going to be available starting today at if you are over here, you got an email that's got a link in it, which you are welcome to share with your friends and colleagues. And the new lifetime membership, single payment, $499, gets you current and future access to all of the material that's on the online academy. and it will get you a $100 discount on the future in-person courses. So feel free to share that with your colleagues and get them on. We do have a graduated payment plan, 4 payments there available as well. And there is a student rate available as well. Just shoot me an email and I can hook you up with those. So $4.99 lifetime membership, Black Friday deal. Starting today, it's available, and that will end after Black Friday is done. Okie doke. I was looking forward to today to have a little bit more of a discussion, Brian, with you and with anyone else who went to the Neurodynamics Congress that took place in Dallas this past week or two ago. I was sad to have missed that. Talked to Cody DMAC. He was disappointed I wasn't there, but life had other plans for me. And Brian, you mentioned you dropped a question on the community forum on NeuroCentric approach about trigger points. Can you reiterate your question, Brian, and talk to me a little bit about that?
Sure. I remember you mentioning this. It could have been a few years ago, even possibly in a podcast, but I think you were at a Stecco seminar. So just be honest, I didn't bring this up to Stecco when he was there. Didn't want him to get mad in his Italian accent. No, I'm just kidding. But I was going to bring up your point because I think you said this at a seminar with him, that you brought up the idea that the Stecco points, trigger points, and I'm pretty sure you also mentioned the areas where cutaneous nerves are at all kind of intersect, basically. They're kind of in the same areas of the body, so we're all kind of looking at the same thing, but just treating it in a different way. Does that make sense? So that was kind of the first part of the question. And then the debate was put out there just briefly by Dr. Bove that they don't exist, but then other doctors, after his presentation, I don't think nobody wanted to confront Dr. Bove because he's very bright.
No,
but
you don't want to
but
confront Jeff Bove. Certainly not.
And he's very confusing. So I always feel like when he tries to explain something, I'm like scratching my head. But anyhow, he's not real big on trigger points existing. He's wrote, I think, a few papers about that. But then I think you respect Dr. Maxwell. He's a very bright person as well. But he thinks there's more of a brain-based mechanism to trigger points, is kind of summing up his idea of why trigger points exist. So I kind of lean more towards what you say, where a lot of these areas do coexist. And by doing dermal traction to like a cutaneous nerve is very similar to working a Stecco point or clearing up a trigger point. I don't know. Just kind of what are your thoughts on all that?
Okay.
I know that's a lot to dissect there. I know I didn't really have a question there. I just wanted your thoughts on, do you still believe all that stuff coexists as one idea, the Stecco points and trigger points and cutaneous nerves, or have your ideas changed in the last few years with that?
Certainly, like all of us, I think my ideas have changed. How have they changed? I'll lean into that and try to describe what I think. And I think it's important before I launch into this to note that I'm speaking off the cuff and I'm speaking about opinion, and I will try to speak in an intellectually honest standpoint and point out to you what I think I know and what I think I might be, call it stepping onto the end of the limb to reach for the fruit kind of positions, or stepping out onto thin ice on. Okay, so in response to your your question on the community forum, one, we have to remember that you're asking a question which is based on your perception after asking a question at a conference. So now we're at least 2 stages, possibly even 3, now from the original statement that the individual made at the conference. So there's all kinds of interesting possibilities that could be for misinterpretation could have gone on there. I'm intrigued by this because I know Jeff Bove a bit, and as I mentioned before, I think it would be a hoot to get him on this environment and actually have him speak a bit about it. And I'll see what I can do to see if he's interested in something like that. But first, regarding what I think I know regarding the trigger point issues, what I can cite is mostly what's in the literature about what other people think they know. Because if you get right down to the brass tacks of it, nobody knows what the hell a trigger point is. What we have is a collection of symptoms and findings on physical examination that have been well described for, as far as I know, going all the way back to the time of folks like Galen. That you have a palpable knot, a taut band. The palpation of that causes familiar pain in the patient and can cause some radiation as well in a direction that is familiar to the patient. And likewise, that when we do something with that particular area, doing something could be what I'm aware of in the literature is sticking a needle in it, either with a traditional Chinese medicine mindset or with a dry needling mindset, but sticking a needle into it or very close to it within a couple of millimeters, we will get something that looks like a twitch response, and then the patient reports that their symptoms are improved. And in the literature from Travell, Simons, and others like Damerholt and Schleip and such, they have described this as a transition from an active trigger point to a latent trigger point. Jay Shah, that I've mentioned several times on here before, at the National Institutes of Health, was the first person to observe a physiological or histochemical measurable thing happening at the area where a trigger point, a palpable nodule that has all the aforementioned cardinal signs of trigger points. Shah measured using needle dialysis locally in those areas and found that there was an upregulation of glutamate, an upregulation of calcitonin gene-related peptide, substance P, and I think some other things as well, possibly tumor necrosis factor alpha. And he noted as well that when that trigger point was treated, in this case with dry needling, and the twitch response was observed, then afterwards, the concentration of those those histochemical elements I just mentioned was lower. And he took that to mean that there was an actual physiological measurable event that was going on in the muscle that could be modulated with therapy. Folks like Jeff Bove and John Quintner, Milton Cohen, they wrote a paper that I've cited several times here and elsewhere on, and several papers actually, on the trigger point pathophysiology, and they know that in other research, it is apparent that when you constrict a nerve, or if you alter its blood flow long enough, then the nerve will exhibit what's called an antidromic reflex. These are afferent nerves typically. And that antidromic reflex means the nerve sends a signal from the cell body to the periphery, and that causes a release locally in the area of that blood flow restriction for the nerve to release the exact same chemicals that Jay Shah noted. So both especially pushes back on this, that pushes very strongly against the idea that trigger points are a muscle-based phenomena. And they're suggesting then that trigger points are more likely a neural phenomena. Now, even more to the point that it is likely some sort of interface problem that then subsequently causes a perfusion problem to the affected nerve. Okay. That's my understanding of the research of those individuals based on my reading. Apologies if I got any of that a bit off, and I'm happy to dialogue with folks. Now, in response to your interpretation of what Dr. Maxwell said, Michael, leaning on the brain end of things there, I don't have a favorite in those categories of, is it brain, is it meat, is it nerve? Well, that's a lie. You guys know me well enough by now to know that I am very neurocentric. But in that category, yes, the person, if they have pain in an area and they, have been told that it's a muscle thing and it feels better when they go to a massage therapist or a chiropractor or a physical therapist and they apply a muscle-based therapy, in quotes here, using, shall we say, a pin and stretch type of maneuver or an effleurage or petrissage kind of maneuver, and they feel better, then it fits within their mindset that is a muscle-based phenomena. However, if I come into that with that particular patient and I palpate and find the same trigger point, and without getting to the depth of the muscle, like just apply a light distraction force at the skin, read YAP or DTM, dermal traction method kind of thing, and their symptoms get remarkably better, then that definitely affects their mental perception of what's going on. And I see that to be an effective way to move into a patient's construct of what's happening in their body, and to lean into that and potentially open the door for other lower risk alternative types of procedures that don't involve a whole bunch of different treatments that are a lot more intensive. Moreover, I would suggest that those kinds of times when you can use that sort of simple skin traction thing that I'm referring to, you can very quickly teach the patient to do the same thing. So there we step right into another place where the psychological literature has spoken to us a bit in terms of pain science in establishing agency in that particular individual. Now they've got something that they can do very quickly to help themselves feel less pain. And they don't have to go pay, $100 an hour to a massage therapist to rub their knots out, or to go to, a rolfer to ascribe some sort of, deeper issue that biomechanically needs to be addressed weekly for an hour for 12 visits or something of that sort. So improving outcomes and reducing costs is kind of where I'm going with that. Now, to talk about what I think the evidence has here, I'd like to share screen here, and I'll try to provide a little bit of the background of what I think I know on this kind of stuff, based on my review of the literature. And I think Brian will actually write this up as a blog post for my own site, and I'll drop that out there to everybody at some point. But a lot of my understanding on this was started to tilt here at this paper. This is Ron Melzak from 1977 in the Pain Journal, very highly respected journal. And he noted about a 71% correspondence between some of the most commonly needled acupuncture points and some of the trigger point mapping that had been provided by Travell and Simons. Now, I think it's entirely possible that part of the pushback you got when you mentioned that, Brian, at the Congress was because of right below, when you do a PubMed search on these kinds of things, you get similar articles. And we can go back to a couple of authors here. And mind you, they're producing papers in the Journal of Alternative and Complementary Medicine. Don't know that I would hold that to the same level of esteem that I would Pain Journal. Also, you see that they are review articles and they're single authors. And so we're looking mostly at their review of the literature and their synthesis of the issue, which is certainly more rigorous than what I'm trying to do here. But still, at the end of the day, it's an opinion based on some of these articles. And we have someone by the name of Birch going back to 2003. We pull their paper up, and he notes Melzak's point from 77, and then in 2003, Birch comes away and says the claimed 71% correspondence of trigger points to acupuncture points is conceptually not possible. Furthermore, even putting this conceptual problem aside, no more than 40% of the acupuncture points in that 1977 study examined could correlate for the treatment of pain, and more likely only 18 and 19% correlate rather than the 71% is claimed. All right, so he pushes back against Melzak there. And now, as you will commonly see in the literature, if you stay with the topic for any long enough period of time, you'll see that it starts to, the pendulum swings back and forth as we talk about more opinions, more review articles. You'll get more evidence quality that looks like this. And then ultimately, somebody, hopefully at some point, will pony up enough money to do something that looks like a randomized controlled trial. And in between there, you'll probably have some case studies or some case series, which are a little higher level of exploration here. And then we can, improve the knowledge base over time like that. So we start with Birch in 2003, I think it was, and then we go to Dorscher in 2008. So 5 years later, he gets paper, comes back, and he's saying that Melzack reported 100% anatomic and 71% clinical pain correspondence to trigger points and classical acupuncture points in the treatment of pain disorders. A reanalysis of this study's data using different acupuncture resources by Birch, a quarter of a century later, concluded that correlating trigger points to classical acupuncture points was not conceptually possible, and that the only class of acupuncture points that could were these so-called Shi points. Moreover, Birch concluded that no more than 40% of the acupuncture points examined by Melzack correlated clinically for the treatment of pain. Birch noted that the acupuncture references support the conceptual comparison of trigger points to classical acupuncture points in the treatment of pain disorders, and their clinical correspondence in this regard is likely 95% or higher. So part of what's happening here is that the definitions of what a trigger point is and the definitions of what an acupuncture point are being, they're changing. I almost said refined, but I'm not sure that we can say that they're being refined. When your definitions change there, your results in something like this are going to change. So a lot of what Dorscher did here was he restricted the definition of the acupuncture points to the so-called Shi points. And in reading some of these other papers, my understanding is that Shi in Chinese means there it is, or something to that effect, which is hearkening to the thing that we're taught in trigger point therapy, to have the patient report when you work on a myofascial trigger point that, yes, there's my characteristic pain. So there's a little bit of an explanation there from my vantage point and how the pendulum can swing over time, and trying to stay, somewhat intellectually honest on this. I doubt seriously, based on my conversations with Jeff Bove and my readings of his research, that he was suggesting that trigger points don't exist. I think probably somewhere in there was a phrase uttered or implied that trigger points as a muscle phenomenology exclusively, or trigger points as a trigger points in that context are not a thing. Jeff is very highly biased on the idea that there's a nerve involvement there that needs to be explored further, and that's indeed part of what he's doing with his ongoing research. So, looks like our apologies over here. It looks like the Facebook Live lead is occasionally blinking in and out. My wireless seems to be giving trouble today. Hopefully that will rectify itself. Brian, does that help at all?
No, it does clear some things up, and I think it can help direct treatment in a better way, along with just explaining to patients what's the mechanism to a degree. Patients don't always want to know exactly. It gets pretty complicated sometimes.
Yeah,
but
a lot of what we have to do, I guess, is to screen that patient for those that want all the extra information and those that don't, and to meet them where they are. I don't I don't go into those patient encounters where a patient says something remarkably different from either my perception of the literature or what the science has provided for us, and wade into it with an idea that I've got to be the smartest guy in the room and have to change that patient's mindset. I try to be a little more nuanced than that. A patient comes to mind recently who was the significant other, new significant other of a patient that I've seen for most of my career intermittently. And that patient that I'd seen for intermittently for most of my career around the time of the pandemic came in, and he was getting ready to go to Burning Man for the first one of those that had opened up after the pandemic. And he had not been vaccinated because he was, his girlfriend was very paranoid about vaccination, and that it was all a scam, and that it was a, an organized plot to try to control people, et cetera, et cetera. And he was concerned, he wanted my response to her argument. So I gave it to him. And then again, 20 years almost of experience of working with this guy, I spoke with him very directly. And I said, I think you're being very foolish to go to a large gathering, unvaccinated, in the middle of a pandemic. And I think, the possibility that you're going to get ill from that is relatively high. And if you do get ill from that, your risks of some of the things that you're afraid of getting, like issues with your heart, are markedly higher if you're unvaccinated versus if you are vaccinated. So he went and got a vaccination, and then but by that time his vaccination that he got was about 5 days before he went to Burning Man. So he went to Burning Man. What do you think happened? He got COVID, and in his mind he was then confused as to whether he got COVID from the vaccination itself, or whether he got COVID because he didn't have enough time for the vaccination to take effect in his body. His girlfriend worked on him pretty hard on that, and she didn't even want to be physically around him after he had been vaccinated. That's how deep her mindset was. So when she came to visit me for another issue, now we're a year distant from that, I had to wade into that interesting hornet's nest. And she was the top-down patient for the pain syndromes that she had. And I treated her as a top-down patient and tried to work through that, being open to her mindset and trying to frame that, my findings in our clinical exam, from that top-down perspective. And she was able to hear it, but at the end of the visit, she really wanted manipulation. So I gave her manipulation. And subsequently, I got a call months later from my patient who was her significant other. And he said she wants to see a chiropractor who focuses a bit more on manipulation. And I was wondering if you had any recommendations. So I referred her out to one of my colleagues that I respect, that I know his practice is a little quicker, a little more focused on that kind of thing. And no harm, no foul. Find a better place for her to be able to exercise her rights, and possibly I planted some seeds there so that she is a little less worried in the world about others having influence and agency over her. We have reached a 1 hour into this. We're trying to keep these to an hour. So does anybody have any wrap-up questions? Okay, I'm not seeing a whole lot there. So remember, I'm counting on you guys that are seeing value in what we're doing here. Please do share it with your friends. We do have the lifetime membership available now for $4.99. That's a Black Friday deal. And that's a one-time payment. I mean, think about it. For 35 hours of current online CE for $500, that's still an incredible deal. And you can pay it once, join in on these kinds of things, use this as a resource, as a community and a knowledge base, and put it in your back pocket for continuing education. All of that material is PACE accredited for you Kairos that are listening. If you're in a state that accepts PACE accreditation, you'll get continuing education hours for your state's controls around how many hours of online CE that you can have. So without further ado, any others that want to see this and didn't get on here early enough, there will be later today a recording of this entire hour put up on the NeuroCentric Approach site with a transcript as well. You're welcome to review that if you like. I see some of you folks that I know, like Keith Gwal and Paul Nolet, are joining us here. I'm glad to see you guys, but you're coming in right at the tail end here. And you guys can go back and review that, and hopefully join us here at 9 a.m. Pacific time next week. Until then, stay curious, go out there and help some people. Take care, guys.